Um, we're now going to look at gastrointestinal medications. Um, let's face it, as a society, we often eat badly, and we often try to make up for these problems with some of these medications we're about to meet that control gastric secretions and irritation and so forth. That doesn't mean that we don't have good uses of these medications as well, but we often see these medications used very commonly by people for various reasons other than maintaining good dietary habits. The GI drugs we're about to meet involve three major categories. First are drugs that control gastric acidity. Secondly, the antidiarrheals. And finally, the treatment of constipation using laxatives. So let's start with treatment of gastric acidity. So gastric acid should be present in the stomach. It should be present in the correct amount, and the stomach is normally protected from gastric acid, which can be quite acidic. Hydrochloric acid, the pH levels are quite low in the stomach, which is helpful in activating the proteases that are present in the stomach and maintaining good gastric function. However, again, we tend to have somewhat poor eating habits that may cause increased gastric acid secretion, eating certain foods that irritate the stomach. In severe cases, this can actually lead to ulceration, or gastric or peptic ulcers. So we have a couple of options here, starting with the antacids, then we'll get into the histamine type 2 receptor blockers, and then finally the proton pump inhibitors. And what we're going to see here is that we're sort of seeing these drugs in increasing levels of effectiveness and sophistication in controlling this problem, starting with the antacids and then finishing or culminating. So what about the antacids? These are so common. We see them advertised. They're very available in convenience stores and supermarkets and so forth. They're simply a base, usually a carbonate or hydroxide base, that combines chemically to neutralize hydrochloric acid in the stomach. For example, this is aluminum hydroxide, which combines with hydrochloric acid to form aluminum chloride and water. Magnesium hydroxide plus hydrochloric acid forms magnesium chloride plus water. Calcium carbonate combines with hydrochloric acid to form calcium chloride and water and CO2 byproducts. And sodium bicarbonate combines with hydrochloric acid to form salt, sodium chloride, water, and CO2. So in each of these cases, we see the hydrochloric acid being combined with the base to form inert byproducts and transform the hydrochloric acid into a non-acidic. The major problems with the antacids is the ones that contain aluminum typically cause constipation. The ones that contain magnesium typically cause diarrhea. So, of course, what they'll often do is combine both products in the same antacid to try to neutralize each other or try to cancel each other out. In other words, the constipating effects of the aluminum product will be canceled out, hopefully, by the diarrhea effects of the magnesium product. It's a tricky situation to try to do this. Acid rebound is a potential problem. This is where when a person takes the antacid, the drug works. It chemically neutralizes hydrochloric acid, but the problem is the stomach then secretes more hydrochloric acid, which is okay while the antacid is in effect. But if you suddenly take away the antacid, we get this rebound effect, which could be pretty severe. And finally, these, as chemicals, can all alter the pH in the body fluids. For instance, in the stomach, some drugs are activated by the hydrochloric and acidic environment in the stomach. If we neutralize that, it can affect drug metabolism. In the GI tract, by causing a more basic environment, this can affect the absorption of certain electrolytes. And in the kidneys, the non-acidification, the alkalinization of the urine can affect drug and electrolyte excretion and reabsorption. The point is these drugs are meant to be used short-term and only on fairly rare occasions. They're probably not meant to be used long term because of all the problems you see here. And most importantly, antacids should not be used as a substitute or a panacea for bad eating habits. So no question, they have some use, but it should be short term and which brings us to our second major option of controlling gastric acidity, and that's the use of these H2 receptor blockers. What they're going to do is block the effects of histamine in the stomach. We don't normally think of histamine as a stomach chemical. We think of it as a chemical that's an irritant to the upper respiratory tract, but it is produced in the stomach, and it binds to a specific type of histamine receptor called the H2 receptor, which increases hydrochloric acid secretion. So obviously we're trying to block this effect, to decrease hydrochloric acid. So these drugs, these histamine type 2 receptor blockers, negate the effects of histamine on the stomach, and these are the cimetidine, famotidine, ranitidine type drugs, very commonly known by their trade names, Tagamet, Pepcid, Zantac. They were developed originally as prescription agents, but because of their effectiveness and their safety profile, were then available over the counter, oftentimes at the prescription dose. A good example of how certain drugs start out as prescription drugs, but because, again, of their acceptability and tolerability and effectiveness, can now be available over the counter. They're generally well tolerated, as I keep kind of alluding to here, in both short-term and, in some patients, used selectively for long-term use. But the Cadillac drugs in controlling gastric acidity, at least right now, are the so-called proton pump inhibitors. The proton pump is an enzyme that pumps hydrogen ions into the stomach. Hydrogen ions then combine with chloride to form hydrochloric acid. So these PPIs, proton pump inhibitors, reduce hydrogen ion concentration and therefore limit the formation of the hydrochloric acid. And once again, these drugs end with this PRAZOL ending, and we recognize, I'm sure, a lot of these trade names like Nexium, Prevacid, Prilosec. These have been a huge improvement in controlling gastric acid secretion in a more long-term, both short-term, but especially in a more long. So these proton pump inhibitors that are shown schematically here, what you see in the middle of the diagram is this proton pump, the enzyme that pushes hydrogen ions from the gastric parietal cell or lining cell into the stomach, where it hooks up with a chloride ion to form hydrochloric acid. At the same time, this pump reabsorbs potassium, but it's really the entry of hydrogen ions into the stomach lumen that we're trying to slow down or limit or at least reduce. So that's what the proton pump inhibitors do. They inhibit this pump. Less hydrogen ion is pumped into the stomach, so there's not enough of it to combine with chloride and form stomach acid. And this is another example of drugs that are very effective and generally well tolerated, especially during short-term use. There is still this chance of acid rebound when they are discontinued. And hopefully, if a patient does have some issue that's causing increased gastric acid secretion, that it's been resolved so that the drug can be slowly withdrawn to prevent this sudden increase in acid effects in the stomach. The long-term effects are unclear. They may affect calcium metabolism in some way, possibly in reducing calcium absorption, which may increase the risk of fracture, but this is clearly still being investigated and somewhat debatable. There's also a suggestion they may increase the risk of gastric polyps, which could be possibly pre-tumors or lead to tumors. But again, their long-term use is still being investigated. But as I said earlier, hopefully we're finding the situation or trying to resolve the initial situation that caused the increased stomach acid in the first place, and therefore be able to withdraw the drugs and maintain a normal gastric function.
Press pause and read this slide before proceeding to the next one for the answer.
We should say a few words about Helicobacter pylori. This is a bacterium. It's often present in the upper GI tract in people with gastric ulcers. And we've always assumed ulcers were due to bad eating or stress, but we know now that in a significant number of patients that if we control this bacterium or eliminate it, the ulcers disappear or are healed. So there's clearly this association. Now, no question, there are a lot of people that have ulcers that do not have this infection. There are some people that have this infection and don't have ulcers. But it's at least something to look at in any person that has developed a gastric ulcer. Is this bacterium present? If so, maybe we can treat it, oftentimes using what's called a triple therapy. It's a proton pump inhibitor plus 2 antibacterials, either amoxicillin and clarithromycin, or metronidazole and clarithromycin, and there are some other variations to this too. Some other therapies involve a fourth drug, something like a bismuth salicylate compound, plus a proton pump inhibitor and 2 antibacterials. But there have been many patients who, when given these therapies, triple or quadruple therapies, and have had this bacterium eliminated, their ulcers were dramatically improved or eliminated. So once again, it's something at least that's worth exploring in all patients that have developed an ulcer. Is it present? If so, and should we treat it and possibly resolve the ulcer? Now there are a couple of other options to control gastric acidity. Acetylcholine increases gastric secretions, so we have the anticholinergics. These are drugs that decrease the effects of acetylcholine in the stomach. There aren't a lot of these because, as we've seen in other situations, when you start to affect acetylcholine in one tissue, you often get effects in other tissues as well. But there's at least this one drug, pirenzepine, that may be somewhat selective for stomach acetylcholine function. Prostaglandins help protect the stomach, and we do have some prostaglandin-type drugs. Misoprostol is the most common that help substitute normal prostaglandin function in the stomach. But again, they cause a lot of side effects. And there are protective agents, notably sucralfate, which when it enters the stomach will actually bind to ulcers that have formed in the stomach lining and create a gel-like protection of the stomach to allow the ulcer to heal. So it's a very nice treatment, often in acute. We're going to now get into the treatment of diarrhea, which can be short-term and it can be fairly transient, but it can be also fairly serious. So the primary options here are first the opioids. Opioid drugs slow down GI movement. When we use these drugs as analgesics, one of the key side effects is constipation. So we're trying to use this effect now therapeutically to slow down GI movement. So you see opioids, especially derivatives or synthetic opioid-like drugs like loperamide and diphenoxylate. Other options involve absorbents, kaolin, and pectin. Supposedly these substances bind onto toxins in the GI tract that are causing irritation. And finally, bismuth salicylate. Salicylate is an aspirin-like compound. Bismuth is a soothing effect on the GI tract. And we see this obviously in drugs like Pepto-Bismol, very common over-the-counter products. So these antidiarrheals, very helpful, again, usually in short term. The only problem we really need to be aware of is if they are overused, they can lead to constipation, which totally makes sense. If you slow down movement through the GI tract too much, fecal material can start to build up and create a constipating effect. But otherwise, short-term use, usually not a huge. And finally, laxatives. What we're generally going to try to do is use some substance that either draws water into the GI tract, We see this commonly with the bulk-forming laxatives, Citrusol, Metamucil. They try to just increase the amount of fiber or bulk to swell up the lower GI tract. And when you do that, you get a rebound effect where the gastric smooth muscle helps expel the contents. Some drugs, the stimulants like Correctol, X-Lax, try to stimulate this smooth muscle directly. And then the hyperosmotic laxatives like Epsom salts and magnesium hydroxide, they're going to try to draw water into the GI tract with the same effect. Try to increase the volume and the swelling of the, not so much swelling, but the size of expand the wall of the lower GI tract to cause it to contract and expel the contents and overcome the constipation. Primary problems with laxatives are if they're overused, they can cause GI irritation, and likewise, if they're overused, they can lead to what's often called laxative dependence. And that is, the GI tract becomes dependent on the laxative to maintain normal evacuation and normal movement. So what you're seeing here is that these drugs, they can be helpful. They're certainly important in certain situations where people might have reduced lower GI movement. Patients recovering from surgeries, people with spinal cord injuries that are put on an opioid drug that slows down movement, oftentimes are put on a laxative, or any patient put on an opioid drug. Once again, opioids tend to slow down GI motility. So oftentimes if we're putting a patient on a laxative prophylactically, it's not a bad idea, it's a good use. But what we should not see is patients start to rely too much on the laxative for their everyday GI function, or substitute the laxative for better eating habits, eating more fiber, drinking more water, and exercising. These are much more natural ways to maintain GI function. Unfortunately, some patients start to rely. So we've talked about GI drugs in the sense of the drugs that affect the secretions into the GI tract or the movement through the GI tract, whether it's too fast and causing diarrhea or too slow and causing constipation. Now granted, there are many other problems that can occur. Lots of infections occur, but we talk about them when we talk about the antibacterial, antiviral drugs. So the drugs we've talked about, their major relevance to us, they can be very helpful in resolving GI problems, which can help our patients participate better in physical rehabilitation. Patients that have a lot of GI problems are not going to be very engageable, or have diarrhea or constipation and so forth. So in that sense, these drugs are indirectly very helpful to what we try to do when we do try to involve or engage our patients. They do serve a critical role in certain situations. Severe diarrhea in newborns. Newborns do not have a lot of body water to play with, and if you have diarrhea, you can cause a dehydration very quickly. I mentioned chance of fecal impaction in people with spinal cord injury, or gastric ulcers and severe trauma and burns. For some reason, patients with severe trauma or extensive burns are subject to gastric ulceration, possibly due to the stress of the injury and the trauma, but for whatever reason, these ulcers, the last thing somebody with these problems of trauma and burns need is gastric irritation and ulceration. So these drugs can be very helpful. The anti-ulcer drugs can be very helpful in that very specific situation. But we should, one more time, be aware of patients overusing these products, like the laxatives, the antacids, and help educate our patients, or maybe refer them to a nutritionist and a dietitian if you do think that their diet could use some beneficial changes to avoid this reliance on these medications. So that's a quick tour of some of the key GI meds, gastrointestinal medications that we often see used, which, as you get a sense of, can be very helpful, but should never ever be overused.